So, doctors, welcome everyone to our second session, Neurology Part 1. So, from the Neurology, there are about 20 prompts. Among them, some are triple star prompts, then double star, and 1 star. And whole of this prompt session will be divided into 3 parts. So, it will take 3 classes to complete all the Neurology prompts. Today will be the first session of our Neurology prompts, and today we'll discuss the first 5 prompts. Excuse me. They are dizziness, collapse, vision problem, transient weakness, and tremor. And these 5 prompts are triple star prompts. Apart from these 5 prompts, headache, facial deviation, and tingling and numbness. These are also most important prompts, that is triple star prompts. So let's start today's session from dizziness. So actually, dizziness is a vague term. It can mean anything. Dizziness can be due to vertigo or spinning sensation, or it can mean like some presyncope or lightheadedness. So we have to be sure what does the patient meaning? What is the patient meaning by dizziness? Is it vertigo or is it presyncope or lightheadedness? So our first question will be to the patient that what do you mean by dizziness? Do you feel like the whole world is spinning around you? That is vertigo. Or you feel like you are going to pass out? That is presyncope or lightheadedness. Did you lose your consciousness? That is syncope. So we have to divide the dizziness into either spinning sensation or lightheadedness. And sometimes lightheadedness can lead to loss of consciousness, which is called syncope. So before discussing the approach to dizziness, let me make you clear about one pathophysiology. So doctors, please let me know whether at any part of the discussion you are having any confusion, because there is some matter of conception here. What is the conception? The conception is, this is our brain, and there are some blood supplies of the brain. These blood supplies can be crossly divided into 2 categories. One is anterior circulation, another is posterior circulation. So if you look at this brain, this is the internal carotid artery, this is the common carotid artery. Here it gets bifurcated and becomes external and internal. And this internal carotid artery supplies the anterior part of the brain. It has 2 branches like anterior cerebral artery and middle cerebral artery. But for right now, just remember that this internal carotid artery is responsible for anterior circulation of the brain. Then let's come to the posterior circulation. The main artery that is responsible for all the posterior circulation is the vertebral artery. Why I am telling this? You will get it understand. So first we have to know that the circulation of the brain is divided into 2 parts, anterior circulation and posterior circulation. And if we divide the brain into 2 parts, that is anterior part and posterior part, and as far as the anatomy of the brain, you can remember there is a specific part of the brain that is called reticular formation or reticular network. This is very much important. Why? Because this reticular network is responsible for maintaining consciousness of us. So whenever there is any impairment of this reticular network, at that time, our consciousness will be impaired. Initially, it can lead to lightheadedness, that is presyncope. But whenever this reticular network is impaired to such an extent that its function will be temporarily off, then we'll lose the consciousness. And this reticular network is situated in the brainstem. So why this is important? So the blood supply of brainstem is from the posterior circulation. That is why any impaired circulation of the posterior circulation, that is any impairedness of the posterior circulation, will cause the loss of consciousness or the dizziness or lightheadedness that is resulting in decreased blood supply to the brainstem. So what I want to say that pre-syncope or syncope will happen when there is impairment of blood supply in the posterior circulation, not in the anterior circulation. This is the main step message of this explanation. May I know if this is clear to every doctors, or should I repeat it once again? Dr. Shifat, did you get my point?
Yes, Bhaiya.
Is it clear to you, or should I repeat it once again?
Clear.
Okay. So, doctors, if anyone is needed to repeat it once again, I'm ready to repeat it. Please tell me, doctors, any of the participants. Okay, let me repeat it once again. So, here I'm explaining the level of consciousness of the brain. What is responsible for our maintenance of consciousness? So there is a particular part at the posterior side of our brain. We call it brainstem. And inside the brainstem, there is a particular system called the reticular network. And this reticular network is responsible for maintaining the consciousness of us. So whenever the function of the reticular network is impaired, at that time, our consciousness will also be impaired. Sometimes it will be impaired to some extent. So it will manifest like presyncope or lightheadedness. But when it will be severely impaired, then it will lead to syncope or loss of consciousness. Why I'm telling this? I'm telling this because loss of consciousness or impairment of consciousness will occur whenever there is decreased blood supply to the brainstem, not to the anterior part of the brain. Like if we divide the circulation of the brain, that is the blood vessel, we can divide into two gross parts. One is anterior circulation, another one is posterior circulation. The major artery that is responsible for anterior circulation is the internal carotid artery, and this is the internal carotid artery. After getting upward, it will divide into anterior and medial cerebral artery. And the main artery that is responsible for posterior circulation is the vertebral artery. So why I'm telling this? Any problem in the vertebral artery, that is also called vertebral insufficiency, will also cause the impairment of consciousness. If the impairment of consciousness if the reticular network is impaired to some extent, it will lead to presyncope. We call it lightheadedness. But if the blood supply is severely affected, then the reticular network will stop doing work for a temporary period of time, and the patient will completely lose their consciousness. In medical term, we call it syncope. Why I am telling this? I am telling this because some of us have a misconception that if there is any impairment of the anterior circulation, also the patient will have loss of consciousness or the presyncope features. That is absolutely wrong. Only whenever there is impairment of circulation in the posterior part of the brain, there is impairment of posterior circulation, right after that, the patient will have some presyncope or syncope-like features. So actually, whenever there is impairment of blood supply to the brain, especially the posterior part of the brain, the patient will feel dizziness or syncope or presyncope. But by the term dizziness, in the PACES exam, it can mean two types. Either it is vertigo, that is spinning sensation, or it can be presyncope. In layman terms, the patient may tell that he is feeling lightheadedness. And this presyncope can lead to syncope anytime. And this is the main basic part of approach to dizziness. So doctors, please let me know if this conception is clear to all the doctors. If it is clear, please give a thumbs up reaction so that I can proceed forward to the approach to the dizziness. Dr. Shifat is clear. Dr. Mushfiq is also clear. Dr. Priya is clear. Dr. Monem, are you clear, doctor?
Yes, Paya.
Okay. So let's dig into the dizziness. Dizziness is actually a vague term. In our real life, whenever anyone tells us that I feel dizzy, this can mean a lot. This can mean either the patient is feeling spinning sensation, which is also called the vertigo, or it can mean like that the patient is feeling lightheadedness, which is also called presyncope. Sometimes this presyncope can lead to syncope. So our first question will be to the patient, what do you mean by dizziness exactly? Do you feel the whole world is spinning around you, or you felt like you are going to pass out? This is called the lightheadedness or presyncope. Did you lose your consciousness? That is the syncope. So, but first, by asking this question, we have to divide the diagnosis into two broad terms. That is either vertigo or presyncope and syncope. These are the two broad categories of dizziness. So let me discuss first the approach to the presyncope or syncope. But before that, if anytime in the PACES exam, anyone tells that he has lost the consciousness, the next important question is the duration. That is for how long. If it is less than 1 minute, it is syncope. But if it is more than 2 minutes, it will be either hypoglycemia or seizure. Please, this is very much important for syncope or the loss of consciousness, because this syncope can be given with the prompt of collapse also. Only the period of loss of consciousness is very much important. Like sometimes in the PACES exam, one time it happened at Delhi Center, the patient was having seizure and she was not having any jerky movement, any frothiness of mouth. Only the duration of loss of consciousness was more than 2 minutes. Nothing else was there. That was a case of hypocalcemia induced seizure. Patient was having history of hypoparathyroidectomy, and she was having a thyroidectomy scar. So why I'm telling this? In the PACES exam, sometimes this jerky movement may not be given there. So the only way to make the diagnosis is the duration of loss of consciousness. If it is less than 1 minute, it will be syncope. I will tell you what are the differential diagnoses of syncope and presyncope. But if it is more than 2 minutes, it will be either hypoglycemia or it will be conversion of seizure. This is for 100% sure, and this is very much important to remember. That is the duration of loss of consciousness. Okay. Among the vertigo and presyncope or syncope, now I'm discussing the approach to presyncope. Like if the patient complains that he was about to lose his consciousness, and sometimes he can also lose his consciousness, that is syncope. So what are the differential diagnoses of presyncope and syncope? To remember the differential diagnosis, you can remember a mnemonic. The mnemonic is NCP. It's a political party. It is called National Communist Party. So here, national goes for neurogenic, communist goes for cardiovascular causes, and party goes for postural hypertension. Let me discuss first the neurogenic causes of presyncope or syncope. But before discussing this, let me tell you how the neurogenic syncope occurs, the pathophysiology. So this is our heart. These are the atrium and these are the ventricle. And there is a particular area at the junction, we call it AV node. And this AV node actually controls the emptying of blood from the atrium to the ventricle. So if anytime we can inhibit the AV node, we can also control the cardiac output. And this AV node has a direct connection with the vagus nerve. So in short, if we can stimulate this vagus nerve, this can inhibit the AV node. Eventually, sorry, there is sound coming. Okay. So if we can stimulate the vagus nerve, this vagus nerve has a power to inhibit the AV node. And by inhibiting the AV node, we can control the emptying of atrium into the ventricle. And whenever the ventricular input becomes less, the ventricular output, also the cardiac output becomes less. And when the cardiac output becomes less, also the circulation to the posterior part of the brain will impair, and the patient will feel dizziness. Sometimes he can lose the consciousness. That is presyncope and syncope. So this is the main cause of neurogenic syncope. Like, it occurs mostly by stimulation of the AV node. And whenever we stimulate the AV node, it becomes inhibited. That is the characteristics of the AV node. And this stimulation occurs through stimulation of the vagus nerve. So in most cases of the neurogenic syncope, this is the pathophysiology. So let me discuss what are the causes of neurogenic presyncope or syncope. This can be vasovagal syncope. In vasovagal syncope, this will occur due to the some emotion or stress. Due to sudden outburst of some emotion or excessive stress, or can be due to some dehydration. The vagus nerve will stimulate it, and eventually it will stimulate the AV node, which will decrease the cardiac output, and eventually the patient will feel lightheadedness. Sometimes she can also lose the consciousness. In the PACES exam, if this case is given, most of the time she is a young female and she is going to work outside, like she is in the market. This is the type of scenario that is given in the PACES exam. So she will be working at the market where there is hot, humid climate, and she's sweating a lot. Suddenly, she lost the consciousness. But the duration of loss of consciousness will be less than 1 minute. In most cases, it will be only 30 to 40 seconds. And she will get back to normal automatically. This is how the vasovagal syncope occurs in the PACES exam. Then the second cause is subclavian steal syndrome. Okay, how the subclavian steal syndrome occurs? Let me tell you the pathophysiology. Here, the culprit is not the vagus nerve. Here, the culprit is someone else. So this is our arch of aorta. This is the brachiocephalic trunk. This is the carotid artery, and this is the subclavian artery. And from the subclavian artery, two artery arises. One artery gives blood supply to the hand, and the another artery is the vertebral artery. So what happens whenever there is some obstruction proximal to the origin of the vertebral artery, like this one? This can be due to some obstruction like atherosclerosis, or sometimes arteritis can narrow this lumen. So what will happen then? If this lumen becomes narrower, the blood supply to the distal end will also become lower. So whenever this patient will do some activity with his hand, this hand will need extra blood. But through this obstruction, the blood supply is becoming less. So to meet this blood supply, he will going to drag the blood from this part. So what will happen? This is the vertebral artery. Through this artery, instead of going to the brainstem, this blood will encircle and come to the hand. And the patient will have some decreased blood supply to the brainstem, that is reticular formation, and eventually the patient will have presyncope that will lead to syncope. May I know if this pathophysiology of subclavian steal syndrome clear to all? This case has come in the Pakistan center. The case was subclavian steal syndrome. She was doing some activity with her hand. Suddenly, she lost her consciousness. And this is how the loss of consciousness happens. Is this clear to all the doctors? Should I repeat it once again? Please tell me, doctors, if anyone needs it once again, please feel free to communicate. Okay, many doctors are telling they are clear. So this is how the subclavian steal syndrome occurs. This is another causes of neurogenic syncope. That is the subclavian steal syndrome. Then another cause is carotid sinus hypersensitivity. What is it? Right at the bifurcation of the carotid artery, there is a plexus called the carotid plexus. And this carotid plexus has a direct connection with the vagus nerve. And it can stimulate the AV node. Like, where is the figure? Yeah, it can directly stimulate the AV node by the vagus nerve. So what happens? By the progression of the age, these carotid flexures become hypersensitive. Like in case of you and me, it will not that much hypersensitive. But in case of our father and mother, it may be hypersensitive. It becomes the sensitivity increases with the progression of the time. So what happens? Whenever there will be some stimulation like carotid massage or some tight collar or some during activity at the salon, if any patient has some neck massage, due to stimulation of this part, the patient will have vagus nerve stimulation. Eventually, the AV node will be blocked, which will decrease the cardiac output, and the patient will have pre-syncope. Eventually, syncope can occur. This is how the carotid sinus hypersensitivity can occur. And this will happen mostly in case of the old age person. That another cause is situational syncope. Situational syncope is also called the Valsalva maneuver. When it occurs, if anyone is straining too much, like if anyone is having constipation or benign prostatic hyperplasia. So before, during urination or during defecation, the patient has to give some straining. And this straining will stimulate the vagus nerve. We also call it Valsalva maneuver. And due to the stimulation of the vagus nerve, suddenly the patient will lose the consciousness by the same mechanism discussed earlier. So these are the neurogenic causes of syncope. Right now, I'm going to tell you the differential diagnosis first. After that, I'm going to give you a definitive sets of questions that will help you instant to make the diagnosis. You don't have to ask the screening question for each. For this dizziness, there will be definitive sets of questions which will cover all the things. But let me know whether anyone is having any kind of confusion regarding the causes of neurogenic syncope. Is it clear to all the doctors?
Can you repeat
Yes.
the situation for neurogenic syncope, please?
Okay. In case of situational syncope, what happens? Like if the patient strains, what do we mean by strains? Like if anyone is having constipation. So to relieve the constipation, patient has to strain. And if we do the strain, our pressure inside the diaphragm will increase. And by certain mechanism, it will stimulate the vagus nerve. And there's a particular name of this procedure. It is called the Valsalva maneuver. Like if you want to take breath against the closed glottis, it will increase the pressure above the diaphragm. That is, it will increase your interthoracic pressure. Whenever you will strain, also the interthoracic pressure will increase. And whenever the interthoracic pressure will increase, it will stimulate the vagus nerve. And whenever the vagus nerve will be stimulated, it can inhibit the AV node. Eventually, the cardiac output will be decreased and patient will have presyncope or syncope. That occurs in case of constipation and benign prostatic hyperplasia. May I know, Dr. Mushfika, am I being able to make it clear now?
Yes, sir. Okay.
Okay. Please, doctor, during my discussion, if anyone is having any kind of confusion, please inform me. I will repeat it 1,000 times.
Doctor,
So
in the
this-
case of corrosive hypersensitivity, it's usual
Yes.
old patient?
No. It will occur during the old age. The older
Only in
patients.
the old age. Only old
Yeah.
age, huh?
Old age.
Okay. Oh.
So these are the neurogenic syncope. Now let's proceed to the cardiovascular causes. That is National Communist Party. Here communist goes for cardiovascular. So regarding the cardiovascular causes of syncope, we can divide it grossly into two parts. It can be due to outflow obstruction or it can be due to any arrhythmia. Let me first discuss the outflow obstruction. So if we think of the cardiac circulation, the heart gets blood supply from the lungs. And after getting blood supply from the lungs, the heart gives the blood supply to all the parts of the body, especially the brain. So if anytime any structural problem occurs in the heart, that will impede the cardiac output. That can cause syncope. The examples are aortic stenosis and hypertrophic obstructive cardiomyopathy. At the same time, if any time there is any impediment of blood supply, that is returning of the blood from the lungs to the heart, that will also cause the same type of syncope. And the type of syncope is their exertional. Let me tell it once again. Suppose I'm sitting here right now. I'm sitting in front of my table and I'm delivering the lecture. So my heart will need, my heart is going to pump, and my heart is going to pump the blood to the brain. But whenever I'm doing some exertion, like I'm running, I am walking, at that time, I will need extra blood supply. And this has to be met by my heart. But if my heart is having some structural abnormality, which he cannot bypass, so the cardiac output will not be increased to meet the demand. So eventually, whenever I'm going to run, I will lose the consciousness. And that will happen for every time in case of structural heart disease like aortic stenosis and HOCM. Like whenever the patient is going to run or going to exert, he may lose the consciousness in case of aortic stenosis and hypertrophic obstructive cardiomyopathy because of compromised left ventricular cardiac output. But also, this left ventricle gets the blood from the lungs. So, if there is any impediment of blood supply from the lungs to the heart, that may also cause the same type of syncope. That is exertional syncope. Like whenever the patient is running or doing some exertion, he may lose the consciousness. And the cause is pulmonary hypertension. These cases come. This is an atypical case, and these cases come in the Thiruvananthapuram one time and also in the Pakistan center. Like the patient is having pulmonary hypertension, and during exertion, she lost the consciousness. So that is why whenever there is any outflow of... Is any question from the doctor? Okay. So in short, I can tell that if there is an outflow obstruction, this outflow obstruction can be from the left ventricle to the brain or can be from the lungs to the left ventricle. That can cause this presyncope or syncope. Then another cause is arrhythmia. In case of arrhythmia, the heart rate increases. So due to the increase of the heart rate, the cardiac output also decreases. And there is some pathophysiology for that. We have to go through the physiology of the cardiac cycle to make it understand how the increase of the heart rate decreases the cardiac output. Because whenever the heart rate increases, the cardiac filling time decreases. So if the heart cannot fill in the proper way, it cannot give the blood also in the proper way. That is the reason why arrhythmia can cause presyncope or also syncope. This arrhythmia can be post-myocardial MI, and this can be evident only from the past medical history. This can be drug-induced, like the patient is taking some medication like azithromycin, which can prolong the QT interval. Sometimes in the past medical history, the patient can tell you that I was having some sore throat, and due to the sore throat, I took some antihistamine, and this antihistamine can prolong the QT interval. That can cause some arrhythmia. So drug-induced cause can be there. Age-related causes is there. What is the age-related cause? In the UK, if you go through the NICE CKS guideline, you will see that anyone above 45 years, if present with any presyncope or syncope, we have to rule out the arrhythmia. First by baseline ECG. If nothing is found, we have to do the 24-hour Holter monitoring, that is 24-hour ECG. This is rule there. Because with progression of the age, the chance of having arrhythmia increases. And the manifestation can be only in the form of dizziness. This can be only the presyncope. Then long QT syndrome is a congenital syndrome, also the Brugada syndrome. These are the arrhythmia which can cause the presyncope, or sometimes it can also cause the syncope. So let me know if it is clear to all the doctors. That is the cardiac causes of syncope. One is due to outflow obstruction from the heart or from the lung, or another is due to arrhythmia. Any question from any doctors? Is it clear, doctor? Should I proceed forward? Okay. If it is clear, let me ask one question from the doctors. Let me see who can reply to this question. To rule out the cardiovascular cause of syndrome, like what important question we have to ask to the patient in the family history?
Sudden
Sudden cardiac death.
Wonderful answer, doctor. Sudden cardiac death. That is why, if you go back to the PDF that I have provided to all the participants, in the past medical history, in the family history, there's a point there that any family history of sudden death, it has to be asked in any case of pre-syncope or syncope, or in any case of palpitation. This question has to be asked, whether there is any family history of sudden death. Sometimes the surrogate will not reply, will not give you the answer if you ask that any family history that I should be aware of, unless you ask this question specifically. Wonderful job, doctor. So these are the causes of cardiovascular syncope. The last is party, that is postural hypotension. Sorry. To remember the causes of postural hypertension, there is a wonderful mnemonic. The mnemonic is HANDS. Here H goes for hypovolemia. This hypovolemia can be due to diarrhea or vomiting, or can be due to some diuretics. Then A goes for Addison's disease or anemia. N goes for autonomic neuropathy. This autonomic neuropathy can be due to diabetes or can be due to advanced Parkinson's disease. Initially, the Parkinson's disease patient will not have autonomic neuropathy, also with the diabetic patient. This will manifest in the advanced stage. Sorry. Then D goes for drugs. These are the vasodilator drugs, like alpha blocker, ACE inhibitor, and diuretics. And S goes for steroid withdrawal. If anyone is taking steroid for a long period of time, and suddenly she has forgotten to take the steroid, she can present the complaint of syncope or collapse. So this goes for HANDS. So may I know if it is also clear to you? If it is clear, please give a thumbs up reaction to me so that I can proceed forward. Okay. So these are the causes of pre-syncope and syncope. But all these differential diagnoses can be ruled out by asking three simple sets of questions. They are the questions of before, during, and after. Among all these three sets, the most important one are the before. So what questions we have to ask in the before sets? We just have to ask two simple questions. That is working and feeling. What was he working? What was he feeling? Just by asking these two questions, you will get your diagnosis. Let me tell you. So in the working, we have to ask, what were you doing before this episode? Feeling. Before this episode, did you feel any unusual sensation like racing pace of heart, feeling sick, or excessive hot? This feeling sick or excessive hot occurs in case of vasovagal syndrome. The patient will feel hot. The patient will feel some nausea. Any smell or tummy discomfort. This is epigastric discomfort. This is found in case of case of convulsion. That is temporal lobe seizure manifest in the form of unusual smell or tummy discomfort. So only by asking these two sets of questions, you will get your diagnosis of pre-syncope or syncope. Let me give you an example. Like if the patient tells you that before this episode, I was standing from the sitting position, what will be your diagnosis? Can anyone tell it?
Well, doctor, can you repeat?
It's like I'm telling that the pre-syncope or syncope diagnosis can be made only by asking these two questions of before. That what were you doing? Did you feel an unusual sensation? Like if the patient tells you that I was before this episode, I was standing from the sitting position. So what would be your diagnosis?
Postural hypertension.
Exactly, doctor. This would be then postural hypertension. Right after that, you can jump into the postural hypertension. Suppose if the patient was telling that before this episode, I was wearing a tight collar, what is your diagnosis then?
Rotative hypersensitivity.
Exactly, doctor. Suppose if the patient tells you that before this episode, I was doing jogging in the morning in the park, and suddenly I lost my consciousness. What is your diagnosis?
Cardiac.
Yes, cardiac, exactly, doctor. And this is very much simple. If you ask the same question in the exam, the patient will give you the typical answer. Anytime any exertional syncope, it is cardiovascular, due to outflow obstruction. Either the outflow obstruction will be from the heart, most cases it will be from the heart. In real case, it can be from the lung. And this aortic stenosis or HOCM is a very much common case in the PACES exam. Why this is very much common? Because this case can be used both as a short case and as a long case. Like at one carousel, this aortic stenosis patient can be given as a short case in the cardiac station. But at another carousel, at another day, this same patient will be used as a non-clinical consultation with the prompt of collapse or syncope. So this is very much simple. Suppose if the patient tells you that before this episode, I was watching television, suddenly I felt some racing pacing of heart. What is the cause then?
Arrhythmia.
Yes, doctor, arrhythmia. So this is very much simple. That is why only by asking, working, and feeling, you will get you all the diagnosis of the pre-syncope and syncope. After that, okay, if the patient tells you that before this episode, I was doing marketing in a local market and I was sweating a lot. Suddenly, I felt some hot-like sensation. I was feeling sick, and then I collapsed. What is that? What is the diagnosis then?
Vasovagal.
Yes, doctor. Vasovagal syncope. And this vasovagal syncope has come many times in the PACES exam. It will be a dummy case, and it will be a middle-aged or youngest lady, and she will do some activity where she's sweating a lot. Right after the before, we have to ask some other questions for the during episode. Already we have asked that how long the episode lasts. If it is more than 1 minute, if it is less than 1 minute, then it is syncope. But if it is more than 2 minutes, then it is hypoglycemia or seizure. So we have to ask, do you remember what happened? For the during episode, we have to ask 3 questions. The first question is, do you remember what happened during that episode? To differentiate syncope from pseudosyncope. Whether the patient is actually having true syncope or not. To make it diagnosed, we have to ask this question. Do you remember what happened? Then during that episode, was there any jerky movement, tongue biting, frothiness of mouth, soiling of clothes during the episode? And also after asking this question, we have to tell sorry. Because we are asking some personal question of soiling of clothes. That is, I'm sorry to ask that question. And please be remember, this jerky movement and tongue biting and frothiness of mouth can be found in case of normal syncope also. So it is not like that in all the cases of seizure, we will get it. We can get it also in the case of syncope, whenever there is temporary loss of blood supply to the brain. That is why to differentiate from syncope from the seizure, the only way is the duration of the loss of consciousness. In the PACES exam, sometimes the syncope patient can also have this jerky movement and tongue bite that occurs due to the transient ischemia of the brain. So, and the third question is any change of color during the episode. Because in case of vasovagal syncope, the patient tends to get pale. But in case of seizure, cyanosis can happen. So these are the 3 questions. After these three questions, for the after episode, we have to ask these 3 questions. The first and most important question for the after set is the how did you get back to normal? Was it spontaneously or by any sugary drink to exclude the hypoglycemia? Then any confusion, headache, or limb weakness after this episode. This is post-ictal confusion. Then this is the question of welfare. Any injury following the episode? And if you ask these sets of questions, all the diagnosis of pre-syncope or syncope will come into your hand. And this is all for pre-syncope and syncope. Now let me ask from the doctors whether anyone is having any kind of question. Let me tell you one additional thing. That is to remember the features of Addison's disease, there is a wonderful mnemonic. The mnemonic is double loss, double T, and double hypo. So what does double loss means? Double loss means loss of weight and loss of appetite. Double T means tanning of skin, that is the hyperpigmentation of the skin, and tummy pain. In Addisonian crisis, patient will have tummy pain. And double hypo means hypotension and hypoglycemia. So this is a simple mnemonic to remember the cause of Addison's disease, features of Addison's disease. And this is all about approach to pre-syncope or syncope. Please let me know whether anyone is having any confusion regarding the approach of pre-syncope or syncope. Right after that, we'll start approach to the discussion to the approach of vertigo.
Sir, I have a question.
Yes, doctor.
Sir, in Addisonian crisis, why this tummy pain happens? Is it because of low blood pressure that is
No,
due to
doctor.
the bowel?
It's I don't know the exact pathophysiology, but what I have come to know that there happens some acute abdomen-like feature. And sometimes there can be hypercalcemia also in the Addison's disease. That can cause sometimes the peptic ulcer disease-like presentation. But in case of Addisonian crisis, patient will have diffuse tummy pain, like acute abdomen. I don't know the exact pathophysiology why this tummy pain occurs in case of Addisonian crisis, but it is there.
Okay, sir.
Okay, thank you, doctor, for asking the question. Any other question from any doctors? Dr. Lim, do you have any question, doctor? Any question? Is it clear to all the doctors? The approach to PC.
No question so far.
Yes, doctor. Okay. Should I proceed forward? Should I discuss the approach to vertigo now? Is it clear to all the doctors? Please give me a thumbs up reaction so that I can make it understand. Okay. Now let's discuss the approach to vertigo. Like from the initial question, if the patient complains that he is feeling the whole world is spinning around him, so this is vertigo. That is a spinning sensation. So how to approach to a case of vertigo? First, we have to analyze the symptom using the mnemonic ODPARA. And what does this ODPARA means? This is given in the PDF sheet. Here O goes for onset, that is sudden or gradual onset. D goes for duration, that is for how long he is having this kind of symptom. I goes for initial episode, that is whether this is occurring for the first time in life. P goes for progression. We have to ask, do you think your symptom is gradually worsening day by day? Then A and R goes for aggravating factor and relieving factor. So we have to ask anything increase or decrease of symptom. And for association, there is nothing here. So this goes for ODPARA. Right after asking the ODPARA, we have to divide the vertigo into constant or episodic. We have to ask whether this vertigo is there all the time or does it comes and go. If it is there all the time, it is constant vertigo. But if it comes and go, then this is episodic vertigo. The mnemonic of constant vertigo is the vice president of Dhaka Medical College. Here V goes for vestibular neuritis. P goes for posterior circulation stroke. D goes for drugs. M goes for multiple sclerosis. And C goes for CP angle tumor. Let me tell you the screening question for each. For vestibular neuritis, in the past medical history, the patient will have history of upper respiratory tract infection. So to rule it out, we have to ask in the past medical history, any recent infection. Sorry, where is there? Okay. Whether there is any recent infection, we have to ask this question. And if there is any recent infection, like the upper respiratory tract infection, and the patient is having vertigo, this can be vestibular neuritis. Again, this vestibular neuritis has two parts. This can be either neuronitis or labyrinthitis. What is the difference? In case of labyrinthitis, the patient will have hearing impairment, where in the neuronitis, the patient will not have any hearing impairment. So these are the two basic differences between neuronitis and labyrinthitis. Both can be told vestibular neuritis. And in the past medical history, the patient will give you a history of recent sore throat or recent infection of the upper respiratory tract. Then B goes for posterior circulation stroke. And this is the most important differential diagnosis that we have to rule out whatever the cause of vertigo is. In the posterior circulation stroke, the patient will have some risk factor in the past medical history. Like the patient can have risk factor of diabetes or hypertension. Patient can be smoker. Patient can have dyslipidemia. This history will be there. And whatever the cause of the vertigo is, for all the cases, we have to rule out the posterior circulation stroke in the physical examination also. How to rule out in the physical examination of the posterior circulation stroke? That is, in posterior circulation stroke, all the time the cerebellum will be affected. So we just have to do the finger nose test. Why I am telling this? Suppose you may be given a case of benign paroxysmal position of vertigo. The diagnosis is there. But even for that patient, we have to do the finger nose test to rule out the posterior circulation stroke. This posterior circulation stroke needs to be ruled out for every case of vertigo, because this is the most significant and dangerous of all the differential diagnoses. Then D goes for drugs. It will be evident from the medication history, that is PDF, past medical history, drug history, and family history. The drugs responsible for causing vertigo are the phenytoin and gentamicin. Then N goes for multiple sclerosis. Multiple sclerosis can cause vertigo by affection of the cerebellum. So we can ask the screening question of multiple sclerosis that, is there any previous episode of weakness at any parts of the body? Is there any balance problem? Balance problem in the cerebellum. These are the screening question for multiple sclerosis. Then C goes for CP angle tumor. In CP angle tumor, patient can have vertigo because of involvement of the cerebellum. And for any case of intercerebral space occupying lesion, the screening question will be, is there any headache that is increased by coughing, sneezing, and bending forward? That is features of rest ICD. And that's all for the constant vertigo, PP of DMC. Then if the patient complains of episodic vertigo, like the vertigo comes and goes, right after that, we have to identify whether this is triggered or whether this is spontaneous. If it is triggered, like if it is triggered by doing some activity, then the differential diagnosis are two. Either it will be BPPV or postural hypertension. In BPPV, the patient will have a tendency to move the head from side to side while lying. And in postural hypertension, typically the patient will stand from the sitting position. So this is the triggered cause of episodic vertigo. If it occurs spontaneously, then there are two differential diagnoses. This can be either migraine or Meniere's disease. Regarding the migraine, there is a specific type of migraine, we call it basilar migraine. In this basilar migraine, patient will not have any headache. The symptoms will be only the vertigo. And this migraine is called basilar migraine. It will be spontaneous, there will be no triggering factor. And in case of Meniere's disease, also it will be spontaneous. The screening question is, patient will have some oral fullness. That is sensation of fullness inside the ear. We have to ask this question, that do you feel any fullness inside the ear? We call it oral fullness. This is for Meniere's disease. And this also all goes for the approach to the vertigo. Let me know from the doctors whether anyone is having any kind of confusion from the approach to the vertigo.
Doctor, can you summarize or leave?
Okay, we just have to ask whether it is constant or episodic, like whether it persists or it comes and goes. If it persists, then the differential diagnosis is vice president of DMC. Here, V goes for vestibular neuritis, P goes for posterior circulation stroke, D goes for drug-related cause, M goes for multiple sclerosis, and C goes for CP angle tumor. We have to rule out each one specifically by asking the past medical history and also the screening question. For vestibular neuritis, it can be ruled out by asking the past medical history. For posterior circulation or stroke, this can be suspected by looking at the past medical history, like whether the patient is having any risk factor in the past medical condition. This drug-related cause can also be ruled out from the medication history. There is no specific screening question for this. For the multiple sclerosis and CP angle tumor, there are specific screening questions. The screening question for multiple sclerosis is that we have to ask any episode of weakness previously. Because we know in multiple sclerosis, there are relapsing and remitting conditions. So the patient will have repeated episode of weakness. To rule out the CP angle tumor, we have to ask, do you have any headache that is increased by coughing, sneezing, and bending forward? So this is all for constant vertigo. For the episodic vertigo, we have to look whether there is any triggering factor there, like whether anything brings on the symptom. If the patient tells you that whenever I move my head from side to side while lying in the bed, I feel the whole world is spinning around me, this is called BPPV. If the patient tells that whenever I stand from the sitting position, then this is posterior hypertension. This case has not come up to now. Only this BPPV has come. Neither this migraine and Meniere's disease has come. Only the BPPV has come up to now in the PACES exam. And this is all for vertigo. Any question from any doctors? Dr. Jahid, do you have any question?
No, sir.
Okay. Dr. Surya, any question, doctor?
Sir, I have a doubt.
Yes, doctor. Please
Like
ask.
this low BP, high BP also, that is hypertensive emergency and urgency.
Yes.
That also will cause dizziness, right? Due to
No.
posterior.
No, doctor. I have not seen up to now, and in the PACES exam up to now, never ever this case has come with the prompt of vertigo.
Okay. I asked the dizziness, sir. Dizziness.
Yeah. Regarding dizziness, also, this case has not come with the prompt of high blood pressure.
Okay.
But there is a point.
Okay.
One atypical case has come in the Thiruvananthapuram and Pakistan Center. That is dizziness due to high bulk viscosity. I'm going to discuss it once again. This is the thing.
Okay. Okay.
Like what causes hyperviscosity? This hyperviscosity can be due to polycythemia rubra. Like, okay, let me tell you, there are many causes of hyperviscosity. Say. This can be primary. There are some secondary causes also. Secondary means secondary to any disease. Like if any patient is having obstructive sleep apnea, or if any patient is having ventricular septal defect, this patient can have some reactive hyperviscosity. Like the patient can have some polycythemia due to this reaction of obstructive sleep apnea and ventricular septal defect. This polycythemia will cause hyperviscosity syndrome. The primary hyperviscosity occurs in case of multiple myeloma, or in case of well-dense to macroglomerulonemia. These are the causes of primary hyperviscosity. And these are the causes, secondary causes of hyperviscosity. This secondary hyperviscosity occurs by causing polycythemia. And this hyperviscosity can present with dizziness. And this dizziness is lightheadedness. That is pre-syncope. It will never be vertigo. Why I'm telling this? These cases come at Thiruvananthapuram, and also these cases come at Pakistan Center, and at Dietary exam, these cases come at Kolkata Center. One time it came with the prompt of with the diagnosis of obstructive sleep apnea. The patient was having obstructive sleep apnea, also reactive polycythemia that was causing hyperviscosity, leading to lightheadedness or dizziness. At Pakistan Rawalpindi, this case came with ventricular septal defect. Also, that patient was having polycythemia. And these cases come with the atrial septal defect at Kolkata Center. This is somewhat atypical but these cases come. This hyperviscosity is due to secondary hyperviscosity. That is secondary to polycythemia. This polycythemia is occurring due to obstructive sleep apnea or ventricular septal defect. May I know if there is any confusion regarding this hyperviscosity? Any type of question from any doctors, please? Dr. Surya, did you get it, this point?
Yes, sir. Yes, sir. Thank you.
Okay. Dr. Mushfika, are you here? Doctor?
Yes, sir.
Okay. Dr. Jahid, are you clear, doctor?
Yes, sir.
Okay, any confusion?
No, sir.
Okay. Dr. Amma, may I know if this is clear to you? Because, yeah, doctor. Because right after that, I'm going to give you some real basis cases and you have to give me the right answer.
Okay, clear, doctor.
Okay. Also, before, let me start the interactive session. Also, for the new participant, I'm going to tell you that for the PACES exam, if you want to get your diagnosis earlier, the trick is go to the past medical history, drug history, and family history as soon as possible. And this is my guarantee that in 80 to 90% of the cases, you will get your diagnosis beforehand. If you ask the past medical history, drug history, and family history right after the symptom analysis. And this is my guarantee. And inside this past medical history, drug history, and family history, there will be a lot of important information for the PACES exam. You will find a lot of safety netting, lot of issues inside there. So these are very much important. And you have to know what questions have to be asked for this past medical history, drug history, and family history. And there is PDF, I have prepared it, and this is provided to all the doctors. This, you have to make it memorize what questions we have to ask. Unless you ask specific question like whether there is any recent injury, whether there is any recent procedure like dental procedure, the surrogate will not give you the right answer. And the details I discussed in the first session. Now let me give you some real cases. One time a case came, the scenario was a 65-year-old male has come with collapse. So after entering the station, after talking to him, he was telling that I was doing jogging in the morning in the park. Suddenly I got collapsed. This was the history. Then in the past medical history, he's telling me that I'm having some heart problem. My GP told me that I'm having some heart issue and I'm taking the medication for that. In the drug history, he's telling me that he's taking this medication. One is perindopil that has been recently started by the GP due to the heart problem, because recently he was having some heart pain. She was having some tightness of the chest. With this problem, he went to his GP and the GP started for him some medication. These are the medications. These are perindopil, then aminosalicylic acid, then isosulfite dinitrite, also the omeprazole. So these were the medication and this was the past medical history. And he got collapsed while doing jogging in the morning. And this duration was less than 1 minute. So right now, I would like to ask the question from the doctors that what should be the diagnosis here? What can you suspect? You can unmute yourself and you can.
Arrhythmia.
Before arrhythmia, doctor, the patient was doing, it is not arrhythmia, it is aortic stenosis, doctor. Dr. Priya is right. This is aortic stenosis. Did you get my point, Dr. Hassan? Patient was doing exertion.
Mm.
While exalting, if any syncope occurs, this will be due to any outflow obstruction for sure. Okay,
Okay.
this is simple case of aortic stenosis. Can anyone mention one important safety netting for this case?
Drug review like perindrofil and isosorbate
Yes.
dinitrate.
Wonderful answer, Dr. Jahid. You have got to the right point. Can you explain it why you have told this?
Sir,
Dr. Jahid?
they can produce postural hypotension also and
Yes,
precipitate
doctor.
the.
Yes, doctor. Actually, perindrofil and isosulfide dinitrate, these are vasodilators. And vasodilators are strictly contraindicated in aortic stenosis. If you remember the solving and part 2, you will see there that the GPs are the culprit there. Most often they make the mistake. That also happened in this case. The patient was having exertional chest pain due to the aortic stenosis. So with this complaint, he went to the GP. The GP thought that this is a case of angina. Thinking it as angina, he started this medication. That is perindrofil, aminosalicylic acid, and isosulfide dinitrate. And this eventually worsened his condition of aortic stenosis. Did you get my point? Am I able to make you understand why this past medical history,
Yes.
dark history, and family history is very much important?
Because we think this is a correct medication. So
Yes,
why
doctor.
I think about ischemia.
Yes, doctor. And I don't know why. For the UK, they tend to make the GP the culprit all the time. They make the mistakes all the time. So here, these cases come. This is real basis cases. Okay. Let me give you another example. This case came at Rawalpindi Center. This was a 30-year-old female with collapse. So after entering, and from the outside, the blood pressure was given 150/90. So after entering, she was telling that I was just cooking in the kitchen. She was working in the kitchen. She was cooking. Suddenly, she she was taking something with her left hand, and then she got collapsed. But this loss of consciousness was less than 1 minute.
13 নাম্বার সেক্টর যাবেন 2 নম্বর রিলেটেড পড়ে বুঝছেন
Okay. Can anyone tell you? Yeah, Dr. Wakalullah has given the right diagnosis. Can anyone suspect what should be the diagnosis or differential diagnosis there? She was doing cooking in the kitchen. Suddenly, okay. Who has told vasovagal?
Me.
Yes.
Yes, doctor. It is another differential diagnosis will be vasovagal also. You are right, doctor. Why vasovagal? Can you explain, Dr. Hassan?
Because she's cooking.
Yes, doctor.
Longer standing and cooking
Yes.
in the kitchen.
In the kitchen, there can be hot and humid climate. There can be a hot climate there. That is why this will be the differential diagnosis there. And whenever the candidate was starting to examine the hand, he did not got the pulse at the left hand. This was a case of subclavian steal syndrome, but the differential diagnosis will become the vasovagal because she was cooking in the kitchen. And this is a real basis case. This case came at the Rawalpindi Center. Let me ask you another question. Another case. This is a 34-year-old lady. Has come with collapse. After anti-intestation, you're seeing she is a fatty lady. She is having all the symptoms of Cushing disease. She's short stature. And whenever you are asking the question that what brings you here today, she's telling you that today morning, while standing from the sitting position, I felt dizzy and I collapsed. And in the past medical history, she is telling you that she is a diagnosed case of cystic fibrosis. And she has some problem at her lungs called bronchiectasis. In the medication history, that is drug history, she is telling you that I take a medication called steroid for my lung problem, but recently I went to Australia and due to the travel, I missed the medication. So after getting
Adrenal
this,
insufficiency.
yes, doctor, adrenal insufficiency. Is not that very much simple? This is a case of adrenal insufficiency. Did you get it, doctor? How simple is this? If you ask the past question that what are you doing and what are you feeling, you will get your diagnosis in 95% of the cases. And this is the rule here. Let me give you another question.
Doctor,
Yes, doctor.
Doctor, in case of Steele syndrome,
Yes.
what positive sign will I get?
What? Sorry, can you repeat the question?
Positive sign.
Positive sign. Positive sign is you will not get pulse at one limb. It can be left limb or the right limb. Most often it will happen in the left side of the hand. You will not get the left radial pulse. The procedure of examining the pulse is that whenever you are not getting the pulse at the left radial pulse, palpate for the left brachial pulse. If you don't get it, then palpate for the left carotid pulse. Whenever you are going to palpate the carotid pulse, you will get the carotid pulse there. Apart from palpating the pulse, and you have to check all the bruit. And two bruits are important. One is renal bruit, another is subclavian bruit. And this subclavian bruit has to be heard below and above the clavicle on each side of the chest. Did you get it, Dr. Hassan?
Yes, I get. And how do you differentiate from Takahashi?
This is a case of Takasu, doctor.
It's a case of Takahashi. Okay. So,
Yeah. Okay. Any other question from any doctors? Okay. Let me ask you another question. Another real cases case.
Doctor, please, how to differentiate from Takayasu?
Which one, doctor? Can you again repeat?
Avian Steele syndrome. How to
Doctor,
differentiate from Takayasu?
Doctor, your voice is breaking. If it is not a problem, can you repeat it once again?
What is the difference between subclavian Steele syndrome and Takayasu? How to differentiate?
Doctor, it is not separate diagnosis. Here, the subclavian Steele syndrome is occurring due to the Takasu arteritis. Let me show you the real pathophysiology picture. So
Okay.
this is the arch of aorta, and this is the subclavian artery. And here, from the subclavian artery, two arteries actually branch off. One is the vertebral artery, and another one is artery to the limb. Sound is coming. Can anyone mute this? Okay, Dr. Hassan, can you please mute for some time? Okay, let me tell you then. So this is the branch of aorta, arch of aorta. From arch of aorta, this is the brachiocephalic trunk, this is the carotid trunk, and this is the subclavian trunk. In short, we call it BCS. From the subclavian trunk, two arteries get branched off. One is the vertebral artery. This is the vertebral artery. Another artery gives blood supply to our hand. Like this is my hand. So whenever there is some stenosis proximal to the origin of the vertebral artery, this will cause the subclavian Steele syndrome. This stenosis can be there due to some atherosclerosis, or whenever there is inflammation of this artery, we call it large vessel vasculitis. This will cause the narrowing of the blood vessel of this subclavian artery. So whenever there is narrowing of this blood vessel, the blood supply to the distal portion will become reduced. So whenever I'm going to do some activity with my hand will need extra blood. But this narrowing part of the subclavian artery will not be able to supply that amount of blood. So what will happen then? My hand will drag the blood from other side of my body in this way. So in spite of going the blood to the brain, the posterior part of the brain, the blood will come to my hand, compromising the circulation to the brain. And the patient will have problem. Sorry, sound is coming in. Okay. So whenever the posterior circulation of the brain, that is, in spite of going the blood to the posterior part of the brain, that is brainstem, it is going to my hand, the patient will feel dizziness or
ابراهيم اسكت ابراهيم.
Okay, doctor. May I know, doctor, if I am able to make it clear, doctor? I have forgotten whoever has asked the question. Doctor?
Yes, clear, doctor. Thank you.
Okay, doctor. Thank you, doctor. So where was I? Okay, I was about to ask another question. Okay, let me give you another real basis cases. It was a 30-year-old lady with feeling dizzy. After entering the station, she is telling you that I'm feeling lightheadedness. This dizziness means lightheadedness. So she's not feeling the spinning sensation. She's feeling lightheadedness for last 1 week. And from outside, the blood pressure was given 100/60. She is a little bit overweight. In the past medical history, it has been told that she has been recently diagnosed with hypothyroidism. The patient will tell underactive thyroid gland. This was diagnosed 1 month back, and after being diagnosed, he has been provided with a medication called thyroxine. Initially she was having some problem of weight gain. With this problem of weight gain, she went to the doctor. But after starting the medication, she has noticed that she is feeling dizzy and she is losing the weight excessively. So please hear carefully, doctor. The complaint is feeling dizzy, and the patient is telling she is feeling lightheadedness, especially standing from the sitting position. And in the past medical history, the patient is a recently diagnosed case of hypothyroidism. He went to the doctor with a complaint of weight gain. The doctor told him that he is having underactive thyroid gland, and that's why he was started the medication called thyroxine. So right now she has come with a complaint of feeling dizzy, standing from the sitting position. And he thinks that doctor, sound is... Okay, let me complete the question, doctor. So she is telling that she is feeling dizzy standing from the sitting position, and she thinks that this medication is the dose of the medication is being excessive. So he's blaming the doctor that this medication is being excessive. So what do you think? What is the diagnosis here?
Polyglandular.
Okay, that is easy. But what has precipitated?
She has Addison also.
Adrenal insufficiency.
Yes, adrenal insufficiency. So what should be done earlier?
Cortisol first and then thyroxine.
Steroid there.
Yeah, we have to start that steroid. It is truth. But can you notice that it is written in the ICK that before starting for any medication of hypothyroidism, we have to rule out the adrenal insufficiency also. That happened in this case. This patient was having underlying adrenal insufficiency. So before starting the thyroxine, we have to start the steroid. And for this patient, she was having some underlying adrenal insufficiency. The doctor who made the diagnosis earlier missed this point. He did not rule out the underlying adrenal insufficiency. That's why after starting the thyroxine, her adrenal insufficiency has got aggravated. Did you get my point, all the doctors? What I want to say?
Yes, we got you.
Okay. Is it clear, doctor? So this was a mistake done by the earlier doctor. He diagnosed the hypothyroidism, but he did not rule out the underlying adrenal insufficiency. That should be ruled out for all the cases of hypothyroidism. So whenever he started thyroxine, this precipitated his adrenal crisis. And that has happened. The patient is losing the weight excessively and he is feeling dizzy standing from the sitting position. So this is the case. These cases come in the basis exam. So in all this form, all the cases are there in the PDF format. You will get it to practice between yourself. And also with the separate recording, there is physical examination, investigation, and management. And that's all for vertigo, or pre-syncope, and syncope. Let me tell you one another thing. Anytime in the PACES exam, if anyone tells that I lost my consciousness. So right now, we have to take the history from the patient. So it is possible that the patient may not be able to recall all the things. Like whenever he lost the consciousness, whether he was having any jerky movement, any soiling of cloth, he can give some misinformation because he was not actually having the right consciousness. So we have to take the history from the collateral, from the partner also. So this line has to be told to the patient after taking the history. This will impress the British examiner. The line is, after this consultation, I would like to talk to your partner or the person who was present at that time. About these symptoms, like what happened at that time. If you tell this line, this will prove you more professional and will impress the British examiner. This is my suggestion to all the doctors that if anytime anyone is having loss of consciousness in the PACES exam, after completing the history and also the physical examination,
ألف وأسحب ألف من البطاقة 100 أسحب 100 من البطاقة.
okay, tell this line to the patient that after our consultation today, I would like to talk to your partner or the person who was present at that time. This will impress the British examiner. And this is all for dizziness, that is for vertigo and pre-syncope and syncope. And this is a very much important prompt for PACES exam. These cases come from the time immemorial, and this will again come. So let me know from the doctors whether this is clear to all the one.
Yes, doctor, is very clear.
Okay. So let me progress to the next prompt. The next prompt is collapse or loss of consciousness. Actually, by collapse, three things can be there. This can be either syncope or hypoglycemia or seizure. The differentiation can be done only by duration of loss of consciousness. So here I will discuss the approach to seizure actually. So collapse means either syncope or hypoglycemia or seizure. The approach will be same, what are you doing, what are you feeling. But initially, we have to ask these questions. Collapse will mean loss of consciousness for every time. So we have to ask, did you lose your consciousness? For how long? And how many times? Whether this loss of consciousness is occurring for repeated episodes of time. And whether this is when was the last time? That when was the last he lost his consciousness? Excuse me. Then, like previous, we have to ask the same sets of questions for the before, during, and after. What was he doing? What is he feeling? Then all the questions of during and after. This will be the same like the syncope and pre-syncope we have discussed earlier. The same questions will be repeated for the before, for the during, and for the after. Right after that, we can jump into the differential diagnosis of seizure or convulsion. So in the PACES exam, seizure can come in two ways. Also in the real life, there are two broad categories of seizure. One is idiopathic, another one is secondary. In the PACES exam, 90% of the time, it will be given as a secondary case of seizure. And less than 10% of the cases, it can be idiopathic. If the idiopathic seizure comes, at one time it came as a first episode of seizure. So we can tell it as a first episode of seizure, that is epilepsy, after ruling out all the secondary causes. The thing we have to keep in mind that if it is the first episode of seizure of any epilepsy, we have to ensure the referral to the seizure clinic within 2 weeks period. This is the thing we have to keep in mind. That if it is a recurrence of seizure, we have to look for the cause of recurrence. This cause of recurrence can be missed medication, like loss of compliance, that missed meal, missed sleep, flashing of light, and stress. Regarding the flashing of light, like the patient can have some disco party the night before that had some flashing of light. That can precipitate the seizure. So these are the causes of recurrence of seizure that can come in the PACES exam. But for PACES exam, this idiopathic seizure is not that much important. But if anytime it comes, as a first episode, we have to ensure the referral to the seizure clinic within 2 weeks period. Because this is written in the NICE case guide. Let me discuss you the secondary causes of seizure. To remember the secondary causes, you can remember a mnemonic. The mnemonic is big monsters in beds daily. There are actually multiple causes of secondary seizures. But right now, I'm going to give you the exact causes that has come up to now in the PACES exam as the secondary causes of seizure. The causes are these big monsters in beds daily mean big mean brain, monster means metabolic causes, invades mean infection, and daily means drugs. These are the 4 causes of secondary seizure for any patient, not only for PACES exam. But in the PACES exam, the brain-related cause that has come up to now can be either due to an ICSOL. This ICSOL most often is due to some neurocutaneous syndrome, like tuberous sclerosis or neurofibromatosis type 1 patient. This has come many times in the PACES exam. You may be given a young patient with tuberous sclerosis who is having facial adenoma, and the prompt is collapse. So anytime you enter into station with a prompt of collapse, you're seeing some 17-year-old man who is having some facial adenoma. You can be sure that this is a case of seizure, and this seizure is due to some ICSOL, like he is having some same kind of tumor inside the brain. And also NF1, that is neurofibromatosis type 1 patient, can be given with the prompt of seizure, and the causes of seizure is intracranial space occupying lesion. So this is for neurocutaneous syndrome. Apart from neurocutaneous syndrome, no other causes of ICSOL-related seizure has come up to now. Then it can be post-stroke seizure. These cases come. If in the past medical history, the patient can give you any history of stroke, this can cause some seizure. And this can be of recent onset, or it can be of past remote onset. Like the patient can have stroke recently, or he can have stroke many years back. Because what happens in a stroke? In case of stroke, some ischemia occurs. So after having the ischemia, it becomes a focus of electrical discharge, that part of the brain. That can cause some post-stroke seizure. After that, it can be due to cerebral venous sinus thrombosis. This case has come. And in the history, there will be there will be some clotting indication there, like the patient can be diagnosed case of systemic lupus erythematosus. And recently, she had some loose motion. After the loose motion, she had some headache, which is increased by coughing, sneezing, and bending forward. And this is a case of cerebral venous sinus thrombosis. And this case has come in the PACES exam. Sorry, as a case of seizure. And there are some particular thing like the clotting question. And regarding the clotting question, I'm going to discuss it during the cardiovascular problem, during approach to the pulmonary embolism. So also in the cerebral venous sinus thrombosis, we have to rule out the clotting problem there. Like the patient can give you a history of taking oral contraceptive pill, or he may be a diagnosed case of antiphospholipid antibody syndrome, or she may be a diagnosed case of SLE. Any factors can be there. So this is for CBST, and this has come in the basis exam. That metastasis can be another cause of seizure. It has come as the form of differential diagnosis. Like one time a case came with a prompt of collapse. In the past, in the history, the patient is a chronic smoker, and he was having a loss of weight, loss of appetite, with coughing out of blood. So it is becoming clearly evident that this is a case of lung cancer. So can anyone tell me if anyone is having some lung cancer-like symptom, and right now he is having seizure, what can be the possible causes of seizure for this patient? From any doctor?
Secondary
Metastasis
Repeat.
and hyponatremia.
hyponatremia
Yes, doctor. One can be hyponatremia, one can be metastasis. These
and
cases.
hypercalcemia. Oh, sorry.
Yes, hypercalcemia can be also there. Yes, doctor. But actually, hypercalcemia does not cause seizure. Hypocalcemia causes.
Hypocalcemia, yes.
Yes. Hypercalcemia does not cause seizure. Hypocalcemia causes seizure. And this hyponatremia has come in the basis exam. The case was hemoptysis, and he was having some loss of weight, loss of appetite. If you remember the first session, we have discussed the screening question for any malignancy is the triple L. That is loss of weight, loss of appetite, lumps and bumps in the body. So this goes for metastasis, and also the hyponatremia can come in the basis exam with a suspicion of malignancy. Also, this hyponatremia can occur in case of advanced CKD. These cases come in the basis exam. I'm going to give you some real example. That hypoglycemia can cause seizure. We all know that. And this is the most important one. Like if any case is given in the basis exam with the diagnosis of seizure, before starting the examination, always we have to rule out hypoglycemia. So we have to offer to measure bedside blood sugar for all the patients of seizure. Then another cause is hypocalcemia. This hypocalcemia is a popular case of seizure. This hypocalcemia, if it is there in the basis exam, 100% time, it will be due to some thyroidectomy. And typically, whenever this case is given, this will be a middle-aged lady, and she will hide her scar mark in the neck with some form of handkerchief around her neck. This handkerchief will be there around her neck to hide the scar mark. And beside the patient's examination date, you will find a BP cuff machine. It will be there because you have to elicit the Trozier sign. You have to make it. You have to do the examination in front of the patient, and you have to elicit the Trozier sign for this patient. And this can be diagnosed only by the past medical history, whether there is any past medical history of surgery. If you ask the patient, do you have any past medical condition that I should be aware of? The patient is not going to give the answer unless you ask any surgery before. Right after that, the patient will give the answer that I had a surgery at my neck, and you will be able to see that she's wearing some handkerchief around her neck. So whenever you are removing the handkerchief, you'll see that there's a scar mark. That is a thyroidectomy scar. And this case has come multiple times in the basis exam. Like in dietary, this case has come at the Dhaka Center. This case has also come in the Delhi Center. And at the Delhi Center, whenever this case came, the diagnosis was seizure, but the patient was not having any jerky movement of hand and feet. Only the loss of consciousness was more than 2 minutes. That is why I'm telling to every doctor that the duration of loss of consciousness is very much important. That another cause is renal failure. Renal failure can cause seizure by uremia. That is uremic encephalitis. Then hypertensive encephalopathy, like whenever the patient is having a high blood pressure, like 180 by 120, this can cause some seizure. I will give you some example how the case has come. That invades goes for infection. Up to now, no infection-related cause of seizure has come in the PACES exam. It has not come up to now. Then DD goes for drugs. The drugs that is responsible for causing seizure that has come in the PACES exam, one is cocaine. Another is alcohol withdrawal. So this goes for big monsters invades daily. So also for any case of seizure, we have to stop the typing, and also we have to do some safety netting. And this is must. This safety netting is must for communication station, also for long clinical consultation. Whatever the cause of seizure is, we have to tell about this safety netting. If we forget to mention about this safety netting for any case of seizure, we lose our mark in the, let me show you the mark sheet, then it will become clear. In this skill, that is the clinical communication skill. Surely we are going to lose the mark if we forget to ask about the safety netting. We forget to ask about mentioning the safety netting. And what are the safety netting? The safety nettings are avoid hobby like cycling, swimming, avoid heavy machinery like sharp cutting object, don't close the door during taking bath. So at least try to mention this safety netting for any case of seizure. So let me ask from the doctors whether anyone is having any kind of confusion from this seizure.
Doctor, safety netting, can you show again?
Okay. There are multiple safety nettings there, but at least try to cover these three ones. That is, avoid hobby like cycling and swimming. Like if anyone is doing swimming and suddenly he is having some seizure, that can put his life into some critical condition. Then avoid heavy machinery and sharp cutting object. And don't close the door during taking bath. These are the three safety nettings. There are multiple other safety nettings also, but at least mention these three words. So if it is clear, then let me ask you a question to see who can make the right answer. Like these cases come. This is a 55-year-old man who has come with collapse. From outside, the blood pressure is given 180 by 120 millimeter mercury. After entering into the station, right after talking to him, he is telling you that he is having some loss of consciousness for more than 2 minutes. And during this period, he was having some jerky movement, swallowing of blood, tongue bites, all the things were there. But in the past medical history, he is telling you that he is having some kidney problem. He is a diagnosed case of CKD. And he takes dialysis. In that drug history, he takes some medication for CKD. That is a CKD-related medication. So right after that, if anyone tells us that he is taking dialysis, that is 3 times in a week, and he is a diagnosed case of CKD, and right now he is having seizure. So what important next question we have to ask to the patient? Can anyone mention?
Headache and family history of bleeding in the head.
No, doctor.
Last
Regarding
session of
dialysis.
dialysis.
Yes, doctor.
Headache.
Dr. Jahid, what was
Last
your answer?
session.
Last
Yes,
session of
doctor. Last session of dialysis. Can you mention why this is important?
Disequilibrium syndrome.
Yes, doctor.
Disequilibrium syndrome.
Suppose the patient is telling you that I have taken the last dialysis 7 days back. Then what would be your diagnosis then? Yes, Dr.
Uremic encephalopathy.
Uremic encephalopathy.
Yes,
Uremic encephalopathy.
in uremic encephalopathy. If the patient tells you that I have taken the dialysis yesterday, then what is the diagnosis, doctor?
Maybe it's equilibrium syndrome.
Yes,
Technique.
doctor, you are right.
Yeah.
This can be dialysis disequilibrium syndrome. Also in the past medical history, he gave history of diabetes, that is diabetic-related CKD. In the medication history, he is taking insulin. So if we make all together, what
Hypoglycemia.
can be?
Mhm.
Yes, Dr. Hypoglycemia. So in the list of differential diagnosis, we can mention anomic encephalopathy if the dialysis is taken more than 7 days back. We can mention dialysis disequilibrium syndrome if the dialysis is taken yesterday. We can also mention hypoglycemia. Can you mention any other cause apart from these 3 causes? Any doctors?
If erythropoietin is taken, then erythropoietin induced.
Doctor, it is unlikely, doctor. In the basis exam, such type of advanced case is not given. Because in the basis exam,
Electrolyte
you are,
imbalance.
yes, doctor, electrolyte
Hypertensive
imbalance.
encephalopathy.
Yes, doctor, hypertensive encephalopathy. So 2 causes we have got. One is hypertensive encephalopathy. Another one is
Electrolyte disturbance, yes. Electrolyte disturbance.
yes,
Hyponatremia.
yes, doctor. Hyponatremia, because in advanced CKD, patient can have hyponatremia. And these were the differential diagnosis there. And this case has come in the basis exam. These are all the metabolic causes of seizure. So that is why past medical history, drug history, and also the family history are the blessings for basis exam if you want to get your diagnosis earlier. And believe me, this technique will help you a lot. Sometimes you may become baffled, like what can be the diagnosis? Don't waste your time. Just go through the past medical history, drug history, and family history. You will get your diagnosis. Just you have to know that what questions you have to ask for past medical history particularly. And regarding drug history, my request to all the doctors will be, don't never miss about the medication allergy. Because the British examiner are very much sensitive about this medication allergy. This is written here in the PDF. This is allergy to any medication. Sometimes there will be positive allergy to medication, and that allergy will not have any relation to the real diagnosis. This has happened for multiple times in the basis exam. So, doctor, please don't forget to ask about the allergy to any medication for any type of prompt in the basis exam. And that's all for collapse for today. So may I know if there's any confusion regarding this case and all the collapse, dizziness, and all of that? Okay, one doctor is clear. Any other confusion? Dr. Ashik, do you have any question, doctor?
Bhaiya, I joined just now.
Okay, doctor. Okay, no problem. Better to complete it from the recording. Okay, there are lots of things to discuss yet. Let me progress to the next problem. That is vision problem. So again, vision problem is a vector. In the basis exam, by the term of vision problem, this can indicate 3 types of problem in the vision. This can be either double vision, or this can be sudden loss of vision or transient loss of vision, or this can be gradual loss of vision. Sometimes we can be given the direct prompt, that is double vision. Sometimes we can be given the direct prompt of sudden loss of vision and transient loss of vision. Or sometimes we can be given the direct prompt of gradual loss of vision. But if the prompt is vision problem, then we have to make it sure what does it mean by vision problem. So we have to ask, what do you mean by vision problem exactly? Is it double vision, loss of vision, or blurring of vision? Difficulty in seeing the sights or difficulty in night vision? This is the initial questions for the prompt of vision problem. Right after that, based on the answer of the patient, we have to approach. Like if the patient complains of double vision, then we have to approach to the differential diagnosis of double vision. If the case is sudden loss of vision, regarding the sudden loss of vision, if anytime any case comes in the basis exam, from outside the prompt is sudden loss of vision, 100% of the time it will be transient loss of vision. And this information will not be revealed unless you talk to the patient. Why I'm telling this? Because all the causes of sudden loss of vision are ophthalmological causes. That is the permanent loss of vision, like retinal detachment, then vitreous hemorrhage. That are ophthalmological causes of permanent loss of vision. And we are going to working there as medicine registered. So will not be given any case from ophthalmology. But if the case is transient loss of vision, for the basis exam, there is a very much popular case that is amaurosis fulvex. So by the prompt sudden loss of vision, you can make sure that this is the case of transient loss of vision or amaurosis fulvex. And this is a medical cause of transient loss of vision. So we don't have to remember all the permanent loss of vision. That is sudden and permanent, like retinal detachment, vitreous hemorrhage, and all the other things. That is not needed at all. Then another one is gradual loss of vision. So let me discuss first the causes of sudden loss of vision. Okay. Before starting for discussion, the approach to double vision, let me make clear one pathophysiology, unless it will become difficult for the doctors to appreciate how this occurs. Excuse me, let me take some water. So this conception has to be made clear to make it understand how the double vision occurs. To the doctors, my request would be if anyone is having any kind of confusion regarding explaining this pathophysiology, please inform me. So this is our cortex, that is occipital cortex. So why we see single object? This is our right eye, this is our left eye. Whenever image from the right eye comes to the occipital cortex, from both the eye, the image merges on the single point of the occipital cortex. That is the reason we see single object. We see single image of a particular object. Is it clear to all the doctors why we see single image of a particular object? Because the rays from both the eyes merge on a single point at the brain occipital cortex. Then, if by some reason the ray from right eye merges here, while the ray from left eye merges at another point of the occipital cortex, we'll see double. Here we'll see single, but here we'll see double. Did all the doctors get my point? Why this patient will see double and why this patient will see single? Please, doctors, please do some interaction so that I may, because this is a matter of conception. Unless you make it understand, you will not get the right idea. So suppose, let me discuss about this patient. Why he's seeing double? Because the image from this eye is going to put on this part of the occipital cortex. And the image from this left eye is going to put on this part of the occipital cortex. So, if we can occlude this eye, the ray is not going to pass from this eye. So, at this point, will the patient see double or single? Doctors, please give the answer.
Single.
Yes, doctor. He will see single. Same, if we close this eye, we occlude the image from this eye, whether the patient will see double or single. Is it clear, doctor?
Yes.
Okay.
Yes.
So again, let's come to this image. Actually, whenever the ray from the eye comes to the occipital cortex, it traverses some media. Like at first from the object, this is the object. From the object, this will pass the eyeball. From the eyeball, inside the eyeball, there are multiple refractive media. There are like aqueous humor, lens, then vitreous humor. These are some refractive media through which the light has to pass. So, if any problem occurs, like in the lens, like in the vitreous humor or aqueous humor, what will happen then? The ray will be divided inside the eyeball into multiple parts. You can make this experiment with some prism or something like that. Like if there is any refractive problem, any problem in this refractive media inside the eyeball, whatever light is passing through it, it will get divided into multiple parts. So what will happen then? So after becoming divided into multiple parts, because this ray is being divided due to some problem in the refractive media, the patient will see double. So for this patient, if we close this eye, like if we occlude the image from the left eye, will the patient see double or single?
Double.
Multiple of double, yes.
Yes, doctor. Exactly. This is the basic idea. You have got to the right diagnosis. So let me tell you once again. So these are basically the ophthalmological causes. And these will never be given in the PACES exam. But this patient, like whenever the images are coming from both the eyes, but they are merging on different points, these are medical causes. So what makes them different? The difference is whenever you are going to close one eye, the double vision disappears. But if the problem is inside the eyeball, even after closing the eye, the double vision will not disappear. Did you get my point?
Yes.
I'm again telling
Doctor,
the
what
medical.
about ophthalmoplegia?
Yes, doctor.
What about diplopia due to ophthalmoplegia?
Yeah,
Muscle twitching.
I'm going to discuss it. So, what are the medical
Okay.
causes of ophthalmoplegia? Actually, medical causes mean this is the eyeball. This eyeball is controlled by some extraocular muscle. There are some 6 extraocular muscles, and the movement of this extraocular muscle is also dependent on some particular nerve, like the 3, 4, and 6 nerve. So, whenever anyone is having some problem at the muscle or at the nerve that is supplying the muscle, he will have some ophthalmoplegia causing double vision. But this double vision will disappear whenever he is going to close one eye. Did you get my point now, doctor?
Yes. Okay.
But if the problem is inside the eye, will the double vision disappear if you close the other eye?
Yes.
No,
Doctor. And
no.
this is the most important history we have to rule out. How to rule this out? Let me do. Now, I think this conception is clear to all. Now, let me approach to the double vision. First, we have to confirm that this is a case of double vision. How to make it confirm that what do you mean by double vision exactly? Do you see 2 images of a single object? Then the most important question comes. That is, when you close your one eye, does the double vision disappear? Did you get my point? Why this question is very much important? Because the double vision has to be disappeared. Because we are working there as a medicine register. If the double vision does not disappear after closing each eye separately, we have to refer the patient to the ophthalmologist. This is not our case. Please make sure, doctors, this conception is clear to all the doctors. And in the double vision, this single question is the most important initial question. That whenever you close your one eye, does the double vision disappear or not? May I know from all the doctors if this conception is clear to each and everyone? Dr. Mohibul Bhai, is it clear, doctor? Dr. Mushfika, is it clear?
Yes, Bhaiya.
Okay. Please, doctor, if anyone is having any kind of confusion, please feel free to stop me at that time. So right after asking this question, we have to ask, when did it start? Did it start suddenly or gradually? Is it the first time? So these are the 5 welcoming questions for the prompt of double vision. Right after that, we can jump into the differential diagnosis. The causes of double vision in the PACES exam are the myasthenia gravis or myotonic dystrophy, then Graves' disease. That is 2 Graves. One is myasthenia gravis, one is Graves' disease. Then it can be due to 6th nerve palsy or 3rd nerve palsy or even 3, 4, 6 nerve palsy. It can be due to internectal ophthalmoplegia or Wernicke's encephalopathy. Regarding all the cases, the 3 most important causes for the PACES exam of double vision are: one is myasthenia gravis, another one is Graves' disease, another one is 6th nerve palsy. Regarding the 6th nerve palsy, it can be unilateral or bilateral. And unilateral has come in the PACES exam. Bilateral 6th nerve palsy has not come up to now. So this is all for double vision. Now I'm going to tell you the difference, what will be the screening question. Regarding the myasthenia gravis and Graves' disease, it will be the complex ophthalmoplegia. Like the patient will see double in all the directions. But in case of 6th nerve palsy, whenever this is unilateral, the patient will see double toward a particular direction. So anyone is not able to move the eyeball at all. This is called complex ophthalmoplegia. And for complex ophthalmoplegia, the differential diagnoses are myasthenia gravis or myotonic dystrophy or Graves' disease and 346 cranial pulse. For myasthenia gravis, the screening question is, do you feel weakness that is increased at the end of the day? For myotonic dystrophy, it has to be diagnosed.
Family history.
Yes, doctor?
Family history.
No, doctor. By doing the handshaking.
Okay.
Can you appreciate why handshaking is important here?
Delayed relaxation.
Yes, doctor. That is why we have to practice doing handshaking to all the patients. Because anytime you can get some positive finding, especially it is important for neuro short case station. Tomorrow I'm going to discuss the approach to the neuro short case in the evening. That is open for the active participant on type 1 or type 2. Here I'm going to discuss all the cases that come in the neuro short case. And what will be the examination steps, how to rule out the differential diagnosis, also the investigation and management. Regarding the Graves' disease, we have to ask weather preference. Regarding the sixth nerve palsy, and it is unilateral, you will be able to make it diagnosed only by looking at the patient, because the patient will have some squint at one eye. You will be typically able to make the diagnosis by seeing the patient that he is having some medial divergence of medial conversion of one pupil. And in the past medical history, the patient can give you some history of diabetes. Apart from this, we can ask this, do you see double in all direction or toward a particular direction, like right or left? So these are the three most important causes of double vision. Apart from that, third nerve palsies can come in the PACES exam. There are two types of third nerve palsy. One is medical, one is surgical. If it is medical cause, the patient will not have any pupillary involvement. Whether it is surgical cause, the patient will have a dilatation of the pupil. Then 346 cranial palsy can be there whenever the eyeball cannot move at all. And internuclear ophthalmology, this is not that much important. This is a spectrum of multiple sclerosis. So the screening question will be any previous episode of weakness of any particular side of the body. And varnish encephalopathy is important for United Kingdom. This case has come at the UK with the prompt of vision problem. And the patient was having alcohol intoxication. Diagnosis was varnish encephalopathy. We have to make it diagnosed by taking the alcohol history. And for all the cases of double vision, we have to tell the patient to stop driving. And this is all for double vision. Please, doctors, if anyone is having any kind of confusion regarding the double vision, please ask me. Doctor, I will be very happy to make the consent. I think everyone is clear. This is a very much easy case, but at the same time, this case has come at multiple times in the PACES exam. So don't forget to ask this important question that when you close your one eye, does the double vision disappear? I have explained why this occurs. To differentiate from medical causes of double vision from the ophthalmological one. In the PACES exam, all the time, the patient will tell you that whenever I close my one eye, the double vision does not disappear. The double vision disappears. He is going to reply you like that. But you have to ask that question. If you don't ask this question, the examiner will cut your mark in the clinical communication skill. Like he has not ruled out the ophthalmological causes of double vision. So mark will be cut here. The next prompt is sudden loss of vision or transient loss of vision. Again, I'm telling, you may memorize the causes of sudden and permanent loss of vision, like the retinal detachment, pictures hemorrhage, and many things like that. But believe me, these are not PACES cases. These are ophthalmological cases. So every time, if the prompt is sudden loss of vision, after entering into station, you'll find that this is a transient loss of vision. And the mighty case is there, that is amaurosis fulgens. So how to approach? Before approaching for transient loss of vision, let me tell you one important thing. In the PACES exam, the prompt that is transient, like transient loss of vision, transient loss of consciousness, or sometimes can be transient weakness. Whatever transient there is, we have to take the history of before, during, and after for all the transient symptoms. And the PACES exam, these are the three transient symptoms. One is transient loss of consciousness. Another is transient loss of vision. Another is transient weakness. These three prompts come in the PACES exam with the complaint of transient. And whenever there is transient symptom, for every case, we have to take the history of before, during, and after. For the transient loss of consciousness, I have already explained what will be the questions for before, during, and after. Now I'm going to tell you for the transient loss of vision. So what will be the initial question? First, we have to ask, when did this occur? Did it occur suddenly or gradually? Is it the first time? Did it affect one eye or both eye? In the PACES exam, the patient will tell you that this is affecting only one eye. Then do you still have the vision problem? To make it confirm that this is transient, then we have to ask this before, during, and after question. For the before is that, what were you doing before this loss of consciousness? For how long the episode lasted? And how did you get back to normal? Did you take any sugary drink? Because hypoglycemia is one of the important differential diagnoses of transient loss of vision. Any type of transient loss of consciousness or any type of transient symptom, one important differential diagnosis is hypoglycemia, that is decreased blood sugar level. So to rule it out, we have to ask, how did you get back to normal? Did you take any sugary drink? And this hypoglycemia is the common differential diagnosis for all the transient symptoms in the PACES exam. That is transient loss of consciousness, or transient loss of vision, or transient weakness. The mnemonic is so many good guys. There are so means stroke, that is eye stroke, or amaurosis fugax. Many means migraine and multiple sclerosis. Good means glucose, that is hypoglycemia. And guys means giant cellulitis. All the cases has come in the PACES exam. So what will be the screening question? For amaurosis fugax, can anyone mention what should be the screening question for amaurosis fugax? Any particular symptom we have to ask to the patient?
Previous attack.
No, doctor. Previous
Speech,
attacks will be
speech.
multiple sclerosis. Yes, doctor?
Speech and weakness. Speech and weakness.
No, doctor. Actually, in amaurosis figures, the patient will feel like curtain is coming down over the visual field.
Yes.
So we can use this line as the screening question. Like, did you feel like a curtain was coming down over your vision? To rule out amaurosis fugax. Then many goes for migraine. In a migraine, sometimes there can be some aura in the form of vision problem. So we have to ask, did you have any headache after this episode of vision problem? For multiple sclerosis, we have to ask any previous episode of weakness at any particular site of the body. And this will be painful vision loss. For hypoglycemia, we have already ruled it out by asking after question that how did you get back to normal? And for giant cellulitis, we have to ask about the headache. That do you have any headache at one side of the head? That is temporal headache.
Shoulder
So
pain.
this
Yes.
is, yes, doctor.
Shoulder pain.
Shoulder, yeah, not shoulder pain.
Yes.
Okay. If the case is giant cellulitis, what important association we have to rule out?
Polymyalgia rheumatica.
Yes, doctor, polymyalgia rheumatica. And these cases come in the PACES exam. The patient was having vision problem and the diagnosis of giant cellulitis. Also at the same time, he was having symptoms of polymyalgia rheumatica. And for any case of vision problem, you have to stop the time. And this is all for transient loss of vision or sudden loss of vision. Let me ask from the doctors whether anyone is having any confusion from this point. Is it clear to all the doctors? Should I proceed forward? Okay. So now let me progress to the next one. That is the gradual loss of vision. Okay. So what should the initial question for gradual loss of vision? The initial questions are when it started, Did it started suddenly or gradually? Is it the first time? Then whether this gradual loss of vision is affecting one eye or both the eye. So these are the welcoming questions for gradual loss of vision. Next, let's go to the differential diagnosis. Here I have mentioned all the possible differential diagnoses of gradual loss of vision. But I will suggest for the PACES exam, we can forget some causes. Like I have not seen up to now in last 4 years, the optic atrophy coming in the PACES exam with the prompt of gradual loss of vision. It has not come up to now in last 3.5 year or 4 years period. What cases come? The diabetic eye disease, hypertensive eye disease, then retinitis pigmentosa and laser-treated retinopathy. This case has come a lot. And regarding if you want to know in general, what are the causes of gradual loss of vision? These are cataract, then diabetic eye disease, hypertensive eye disease. It can be due to macular degeneration. It can be due to clinical significant macular edema. It can be due to retinitis pigmentosa or laser-treated retinopathy or optic atrophy. Regarding the differential diagnosis, you can mention all of them. But you have to make sure what points goes against the other differential diagnosis apart from your main differential diagnosis. Like the diabetic and hypertensive eye disease has come multiple times in the PACES exam. And for this diabetic and hypertensive eye disease, we have to know how to do the fundoscopy. And recently, in last 2 years period, this fundoscopic examination is being given in the PACES exam. We have to practice it beforehand. We have to know how to elicit the positive findings. And there are some particular clue for the fundoscopy examination and particular safety netting. One safety netting is that never touch the patient's head while doing the examination. If you touch the patient head, you lose your mark in welfare. So we have to practice doing the fundoscopy without touching the patient head. The next thing is that we are not working there as an ophthalmologist. We are working there as a medicine background. So we don't have to identify the stages of diabetic eye disease or diabetic retinopathy or hypertensive retinopathy. It is not at all needed. The thing is needed that whether we are being able to identify these particular 4 things. One is papilledema. Another is hemorrhage. This hemorrhage can be point hemorrhage or flame-shaped hemorrhage, whatever you tell. You can just mention hemorrhage. That will be okay. We have to know what is hard exudate. And what is soft exudate. And that is all needed for passing the PACES exam after doing fundoscopy. Like we don't have to identify the artery venous snipping. This is not at all needed for PACES exam. We don't have to identify the silver wiring. It is not at all needed. The examiner will notice whether we are able to identify the papilledema or hemorrhage or hard exudate and soft exudate. And after doing the fundoscopy, we just have to identify these positive physical findings. And that is all. And this fundoscopy actually needs bedside examination. We have to do a lot of examination over real patient unless it will be difficult in the real exam to make it identify. Then, another thing is that retinitis pigmentosa and laser-treated retinopathy. There is a specific clue to make this diagnosis. So what happens in retinitis pigmentosa and laser-treated retinopathy? In the retina, the peripheral photoreceptor cells are destroyed. And these photoreceptor cells are responsible for night vision. So in the PACES exam, if anytime any patient complains to you that is he is having problem in night vision, also he is having tunnel vision, night vision, tunnel vision, then the diagnosis can be either retinitis pigmentosa or laser-treated retinopathy. So before doing the fundoscopy, you can make your diagnosis. If the patient complains of problem in night vision and difficulty in seeing the side, that is tunnel vision, this will be either retinitis pigmentosa or laser-treated retinopathy for sure. For retinitis pigmentosa, it will be younger patient. For laser-treated retinopathy, it will be older patient. And in the past medical history, if you ask about an eye procedure, the patient will give you some positive findings, like he underwent some procedure inside the eye. So sometimes you may not be able to make it identify by doing the fundoscopy, the bony spicules that is found in case of retinitis pigmentosa. It has come in the Pondicherry Center. So even if you are not able to make it identify, just by asking the night vision and tunnel vision, you can be assured that this is a case of either retinitis pigmentosa or laser-treated retinopathy. So doctors, please make me assure that whether any confusion is there regarding the diabetic eye disease, hypertensive eye disease, and also the retinitis pigmentosa and laser-treated retinopathy. How to make it diagnose the retinitis pigmentosa without doing the fundoscopy beforehand. If any patient complains of night vision and tunnel vision, any problem in night vision and tunnel vision, you can be assured that this case can be either retinitis pigmentosa or laser-treated retinopathy. And there are some other causes of optic atrophy. The mnemonic is made in toxin. Then M goes for multiple sclerosis. There are many causes there. I'm not telling you because this is not important for basis exam. Now let me see whether this is clear to all the doctors. Dr. Surya, are you clear about that? This vision problem?
Yes, sir. Yes, sir.
Any confusion, doctor?
No, sir.
Dr. Mushfika, may I ask, do you have any confusion?
No, sir.
Okay. Let me tell you another one thing.
Bhai, I have
Whenever,
a question.
yes, doctor, please ask.
In case of retinitis pigmentosa or laser-treated retinopathy, suppose
Yes.
I diagnose this with this history of night vision, tunnel vision, but
Yes,
in the ophthalmoscopy, I couldn't find the
bony spicule.
like bony spicules like that.
Yes.
Should I tell examiner that I have got this sign, or I should
I
omit
can make
this?
you assure. I can make you assure from my side that you can tell this, that my differential diagnosis is retinitis pigmentosa or laser-treated retinopathy. But against the laser-treated retinopathy, I have not got any positive history in the any eye procedure or any history of diabetes there. I can make you 100% guarantee that if anytime any patient in the basis exam complains of night vision problem and tunnel vision problem, even if you are not able to identify the bony spicule, you can tell these two differential diagnoses. This is 100% guarantee from my side.
But I was asking about the sign. If when examiner asked me what sign did you get, then should I tell about this
I will
or
suggest for
not?
telling that. I will suggest for telling the doctor because all the time you'll not be able, unless you see some real patient of bony spicule, sometimes you may not be able to identify this. But if in the history these complaints are there, I can make you guarantee that this should be the diagnosis. So you can tell that I'm finding some bony spicules at the periphery, even if you are not able to identify it by the fundoscopy. These are some tricks. Did you get my point, Dr. Ashik?
Yes, Bhaiya, clear. Thank you.
Okay. And also this retinitis pigmentosa will be associated with some other symptom. Like in Pondicherry Diet 1, 2025, these cases come with a problem of vision problem. So right after asking the patient like, what brings you here today? There was a surrogate there. He was a young patient. And with a surrogate that is a medical student, he was giving all the answer in one line that I'm having some vision problem for the past few years, this with gradual onset, and I'm having tunnel vision with night vision problem, also with color vision. So what is causing the problem of color vision here? If I explain the pathophysiology, this is our retina. In the periphery, there are cone cells. In the center, there are rod cells. So this rod cell is responsible for color vision. So what happens in retinitis pigmentosa? Initially, the peripheral photoreceptor cells are affected, but with progression of time, it tends to progress inward. Like gradually, it affects the rod cells also. So initially, it starts with only the night vision, but gradually it will also affect the color vision. And that was the symptom the patient was having. The candidate who appeared at this exam, he got puzzled, but somehow he could identify the bony spicules there. And he told it. He got full mark. The surrogate replied in one line that I'm having tunnel vision, I'm having problem in night vision, and I'm also having problem in color vision. So by one line, you have got your diagnosis. If the patient is young, it is retinitis pigmentosa. I can give you 100% guarantee. So I will suggest you to see, if you are not able to appreciate the bony spicules there, you can tell it for sure that I'm getting some bony spicules at the periphery. Because you can forget this thing, what I'm going to tell you right now. In the medicine field, the causes of night vision problem plus tunnel vision plus color vision. These three combination is seen only in 3 diseases in the field of medical science. They are either glaucoma or retinitis pigmentosa or laser-treated retinopathy. Glaucoma, we can forget about it because this is an ophthalmological case. This case will not be given in our basis exam. So this becomes very much clear that we can remember about retinitis pigmentosa or laser-treated retinopathy. Sometimes, if you are not able to identify the bony spicules, just ask the past medical history whether there is any history of doing some eye procedure. If there is no history of doing some eye procedure, you can be sure 100% that this is a case of retinitis pigmentosa. And also, this retinitis pigmentosa has some association. This will be given with part of some other symptom. In the Pondicherry, the patient was having walking difficulty also. So what are the symptoms? There are some genetic symptoms. There are Usher syndrome, Kahn-Sade syndrome, Repsam's disease, Bardet-Biedl syndrome, beta-lipoproteinemia, and Alport syndrome. There are some weird names there. And believe me, these things were not asked there, but you can know it for you better. For Usher syndrome, apart from retinitis pigmentosa, the patient will have hearing problem, also with ataxia. In Refsam's disease, along with retinitis pigmentosa, the patient will have anosmia, that is problem in smell. Then there can be short foot metatarsus along with peripheral neuropathy. In Bardet-Biedl syndrome, apart from retinitis pigmentosa, the patient will be obese and hypogonadism can be there. In beta-lipoproteinemia, apart from retinitis pigmentosa, the patient will have loose motion and ataxia. In Alport syndrome, there will be hematopy. In Kahn-Sade syndrome, there will be involvement of multi-system, like the patient can have some heart failure, the patient can have some heart block. So the patient in front of you can have some pacemaker at his chest. That is the AV block can be there. There can be some endocrine affection like hypothyroidism, diabetes can be there. There can be some ophthalmology. So these are some symptom association of retinitis pigmentosa. The case that appeared at Pondicherry, the patient was having walking difficulty also. So we have to examine the lower limb neurologically for that case. Whether this can be a case of ataxia with Usher syndrome, this can be case of beta-lipoproteinemia, or this can be case of Repsam disease because there was having peripheral neuropathy. And for all case of vision problem, we have to stop the time. And this is all for gradual loss of vision. Again, I'm telling, please practice the fundoscopy. During practicing fundoscopy, please avoid touching the patient's head, and it is not necessary to make it diagnose, pinpoint the stages of diabetic retinopathy or hypertensive retinopathy. It is not needed at all. Just we have to identify whether there is papilledema, whether there is hemorrhage. This hemorrhage can be point hemorrhage or it can be flame-shaped hemorrhage. Whatever hemorrhage is there, please use the term hemorrhage rather than pinpoint hemorrhage or plotting hemorrhage, dotting hemorrhage. In the PACES exam, try to use some broader term that will keep you in the safe side. Don't try to, progressing with some being more smart, like I have been able to make the diagnosis pinpoint. This type of approach can sometimes make you trouble. So rather approach with broader term that I have got some hemorrhage. This can be blood hemorrhage, this can be flame-shaped hemorrhage. That's all. Then try to identify the hard exudate and soft exudate. And that's all. This is very much simple. It needs a little amount of practice only. Now let me know from the doctors if anyone is having any kind of confusion from this prompt. One doctor is clear. Dr. Jahid, may I know? Do you have any question?
Yes, sir, clear.
Okay. Dr. Rafia, any question, doctor?
No, not so far.
Okay. Dr. Mushfika, is it clear with you?
Yes, sir.
Okay. Dr. Mohibul Bhaiya, is it clear?
Clear.
Okay. So this is all about vision problem. Now let me progress to the next prompt. That is the transient weakness. The third transient prompt of PACES exam. Up to now, I have discussed that there are three kinds of transient symptom in the PACES exam. One is transient loss of consciousness, one is transient loss of vision, and this one is transient weakness. But all the time, for all transient symptom, we have to ask the before, during, and after question. So, how to approach to a transient weakness case? We have to ask, when did it occur? Did it occur suddenly or gradually? Then is it the first time? Then, whether this transient weakness affected the hand or leg, whether there was any deviation of the mouth. In the PACES exam, this case is given most often with only transient weakness of the hand. Like in Gayatri exam, this case has come in the Dhaka Center. This was a female. She was having history of mitral stenosis, and she was having transient weakness of the right upper limb. This case has also come in the Delhi Center. The prompt was transient weakness of transient weakness. After entering the station, she was telling that while preparing coffee, she was having sudden transient weakness of the right upper limb, and the cup of coffee suddenly fell from her hand. That was the prompt there. Then we have to ask before, during, and after that, what were you doing before this episode? For how long the symptom lasted, and how did you get back to normal? And these are the differential diagnoses. This can be TIA or hypoglycemia or migraine, that is hemiplegic migraine, or multiple sclerosis, or this can be seizure in the form of TOTS paralysis. Up to now, 1, 2, 3, and 4 cases has come in the PACES exam. 5 number case has not come up to now. So what will be the differential diagnosis? What will be the screening question for each? For all cases of transient weakness, you can keep TIA as the differential diagnosis. We have to look at the past medical history, whether there is any risk factor there, like diabetes, hypertension, smoking, anything is there. And this will be given there. Like sometimes only hypertension can be given there in the past medical history. So this will form the TIA. Then we have ruled out the hypoglycemia by asking the after question. For migraine, we have to ask about the headache. For multiple sclerosis, we just have to ask any similar episode previously. Any similar episode previously. That is multiple sclerosis. And that is all for transient weakness. And for all the cases of transient weakness, we have to stop driving. And as the patient is having weakness, if the patient is having weakness of the hand, we have to check the functional capacities of the hand. If the patient is also having, that if the patient was also having transient weakness of the lower limb, we have to check the gait also. Whatever complaint he was having, accordingly, we have to rule out the complication from the physical examination. And the functional capacities of hand are assessed by telling the patient Can you make a fist and open it for me? And can you please button and unbutton your gown for me? And that is all for transient mutis. Now let me tell you, suppose a hemidiotis feminist has come with a complaint of hemiplegic migraine, and she's taking oral contraceptive pill. So what important safety netting you have to provide?
Stop or to change.
Yes, stop taking bath controlling pill. This will be told by all the common candidates. But what will make you different? Like anything extra information you want to provide apart from stopping?
Arrange meeting with
Refer to
a
female
woman.
doctor.
Yes, doctor. Arrange
Fulfill-
meeting. Because in the United Kingdom, we don't have to only stop the medication. Also, we have to arrange some proper bath controlling for her. That is why we have to arrange a referral to the women doctor. And that's all. It's very much easy. If you do practice this repeated episode, this becomes very much easy. So this is all for transient mutis. Sorry. Now let me know from the doctors whether there is any confusion from this prompt. Okay, two doctors is clear. Dr. Sadiq, may I know, are you clear, doctor? Okay, many doctors are clear. Dr. Monem, are you clear? Yeah, I think all are clear. Okay. So let me progress to the last prompt of today, Neuro Part 1. That is tremor or shakiness of hand. So this tremor can be resting tremor, or this can be some action tremor. This tremor can affect only the hand, or it can also affect the legs, voice, head, all the things. And whenever there is affection of the head and voice, this points to a particular diagnosis. This is essential tremor. So what should be the initial question first? The initial question is, the prompt will be this patient has come with the complaint of shakiness of the hand. Talk to him, examine him, and meet his consent. This will be the prompt from outside. So after entering the station, right after telling the patient that what brings you here today, the patient will tell you that I'm having some shakiness of hand. So we have to ask any other body parts affected, like the legs, head, and voice. We have to give some example. Because if there is affection of the head and voice, this points towards essential tremor as the differential diagnosis. Then whether this occurs at rest or during the movement, that does it occur during rest or during movement? We have to ask this question. Because rest tremor occurs in case of Parkinson's disease. Whether intention tremor occurs in case of essential tremor or in case of cerebellar tremor. Then any change in handwriting. Why this question is important? Because in case of essential tremor, the handwriting becomes bigger. While in Parkinson's disease, it tends to get smaller. We also call it micrographia. Then we have to analyze the symptom using the mnemonic OD panel. That is onset, duration, initial episode. That how did it started? For how long you are having this kind of symptom? Is it the first time? Then progression. Is it gradually increasing day by day? Then A and R, anything increase or decrease of symptoms. And for association, nothing has to be asked. So this goes for OD panel. Then we can directly jump into the differential diagnosis. To remember the differential diagnosis, you can remember a mnemonic that is end your liver with anxiety, alcohol, and coffee. So what goes for end? Here N goes for E and D. E for endocrine cause, N for neurological cause, and D goes for drug cause. Liver goes for Wilson disease. Then anxiety, alcohol withdrawal, and excessive coffee intake can cause some tremor. Regarding the endocrine causes, the causes are hyperthyroidism and hypoglycemia. Regarding the neurological causes that comes with the basis exam, that are important causes are essential tremor, Parkinson's disease, and cerebellar tremor. The drug-induced causes of tremor are the beta agonists like salbutamol inhaler, then lithium-induced tremor, cyclosporin and tacrolimus. Okay, let me ask you one question. That in the PACES exam, can you guess at which station this cyclosporin history can be there? Like I'm telling you that in the PACES exam, there is a particular type for this, like this Parkinson disease patient. This Parkinson disease patient can be given in the short case station of Neuro. Also, this patient can be given at another carousel with another day at the long clinical consultation with the prompt of tremor. Similarly, there is a particular short case station where this cyclosporin history can be there. Yes, Dr. Surya has got the right diagnosis. Renal transplant. That is why this case has become important. Because this renal transplant patient can be given in the short case station. At one carousel, they have put this renal transplant in the short case. At another carousel, they have switched this case with the long clinical consultation. Because this cyclosporin of tacrolimus can cause some tremor. Then liver is Wilson disease. So what will be the screening question? The screening question for endocrine in the form of hyperthyroidism, we have to ask, is there any weather preference? For hypoglycemia, we have to ask the other symptoms of hypoglycemia, like whether during these episodes of hand tremor, were he having excessive sweating, blurring of vision, and excessive sweating and blurring of vision. And did anyone measure his blood sugar anytime during this episode? This is for hypoglycemia. And there will be a clue in the past medical history and drug history. Like in the past medical history, the patient can give you the history of diabetes. And in the drug history, there will be history of taking oral hypoglycemic agent like sulfonylurea, or there can be history of taking insulin. Clue can be there in the PDF, the past medical history, drug history, and family history. So this is all for endocrine. Regarding the neurological tremor, the essential tremor can be diagnosed by family history, also from the initial questions. And whenever you are going to talk to the patient is going to have some head nodding. He's going to dance in front of you whenever you are going to talk to him. Regarding the Parkinson disease, the screening question is, do you think you are getting slower day by day? That is the question for bradykinesia. Then cerebellar tremor, the screening question is, do you have any balance while walking? Sorry, do you have any balance problem while walking? If the patient complains that, yes, I am having a problem in maintaining balance, the next question is, do you tend to fall on one side, on both sides? Do you tend to fall on one side or both sides? If the patient has a tendency to fall on one side, this is unilateral cerebral affection. If the patient tends to fall on both sides, it is bilateral. The differential diagnosis of unilateral cerebral affection is the STD, that is stroke, tumor, and demyelination. If the patient has tendency to fall on both the sides, this is bilateral cerebral affection. The mnemonic is, my alcohol can drive gene. Here, my goes for multiple sclerosis, where there can be bilateral cerebral affection. Also, there can be unilateral cerebral affection. Alcohol can cause bilateral cerebral affection. CAN means cancer. There are some paraneoplastic syndrome that will have bilateral cerebral affection. Then drive goes for drug. The drugs that are responsible for cerebral affection are the phenytoin and lithium. And this lithium case has come in the PACES exam. Also, the phenytoin has come. Then gene goes for genetic disease, that is Friedreich ataxia. So these are the differential diagnoses of bilateral cerebral affection. And the unilateral cerebral affection differential diagnosis is stroke, tumor, and demyelination. To rule out the stroke, we have to ask any weakness at any parts of the body. To rule out the tumor, we have to ask, do you have any headache that is increased after coughing, sneezing, and bending forward? To rule out the demyelination, we have to ask, do you have any previous episode of stroke? Sorry, any previous episode of weakness at any parts of the body? That is demyelination. So there goes for neurological, that the drug causes will be identified from the medication history. To rule out the Wilson disease, we have to ask, any family history of liver disease? This should be the screen question for Wilson disease. Whether there is any family history of liver disease. Then anxiety, we have to ask, what about your mood? Then is there, we have to identify whether there is any recent alcohol withdrawal from the alcohol history, and whether the patient takes excess amount of coffee or caffeine. And these are the differential diagnosis of handshaking or tremor. But from my experience, what I have seen up to now, that candidates most often are able to rule out all the differential diagnoses except the two simplest ones. They are anxiety and coffee. They forget to ask about the mood and forget to ask about the intake of excess coffee. These two simple things are easily missed by the candidates. So doctors, please BSc, please ask separately, what about your mood? What about your coffee? Do you take excess amount of coffee or not? Then, as this is a case of handshaking or hand tremor, we have to check the functional capacities of hand. We have to tell the patient, can you please make a fist and open it for me, and button and unbutton is count for. And also we have to examine the thyroid swelling, ruling out the hyperthyroidism. And this is all for handshaking or hand tremor. Please let me know whether there is any confusion or question from this prompt. And this is going to be the last prompt of today's session. Any question from any doctor, please? One doctor is clear. Another doctor. Okay. Dr. Walker, do you have any question, doctor? Okay. So this is all for today's session. We'll have two other. Thank you, doctor.
No, sir. Thank you. Alhamdulillah, everything clear, sir.
Thank you, doctor.
Thanks, sir.
So there will be two other sessions on neuro that will be needed to complete all the neuro prompts, and this is going to be the last free class of this batch. So if it is okay, then I would like to take some break. And today also the doctors will have some neuro short case session. There we'll discuss all the approach of neuro short case. It will be there from evening. There we'll discuss how the short case appear in the PACES exam, what are the possible prompts, then the steps of examination for each prompt, then what are the differential diagnoses, how we can rule them out, like the steps of differential diagnosis are there in the box format, and how to say the presentation, and what will be the investigation also with the management. I'll try to cover all the things, like more than 90 to 95% things for the neuro short case session. Here I would like to provide to you also the steps of examination for Parkinson's disease, for myasthenia gravis, for myotonic dystrophy, and all the things needed, cerebral examination, all the things will be given there. So we'll have this session tomorrow at 7 p.m. Dhaka time. And this will be free to the doctors for type 1 and type 2. And I'd like to provide the PDF to all the participants. So doctors, if it is okay, then I'd like to take a break for 10 minutes. Then we'll start our practice session from our yesterday prompt. Like we have given some homework from today's prompt, yesterday prompt, and we'll assess the homework from the active participants. And today I'm going to provide the cases also from this prompt. And the doctors who I have enrolled for the type 1, you have to do the practice. Okay. So let's take some break of 10 minutes. And right after that, we'll start the practice session. Okay, doctors, see you later, 10 minutes after. And this is going to be an interactive practice session. You'll see some difference there. See you there after 10 minutes.